Hello, I welcome you all to another Walters Kluwer Renaissance webinar series, recent advances and the application of neurotechnology. Today we have with us, Dr. Lakshmi Narasimhan Ranganathan, who's going to talk about on the first topic of that we have today is artificial intelligence and Internet of the Things. After that, we have a virtual reality, Deceiving the Brain by Dr. Guhan Ramamurthy. And then followed up by the panel discussion. We also have a great chairperson and panelist with us today. I request Dr. Lakshmi to just introduce our panelists as well as chairperson today. Dr. Lakshmi, over to you.
Sir, and I have immense pleasure in introducing Dr. Nirmal Surya, the President of the Indian International Federation of Neurorehabilitation, President of the World Congress for Neurorehabilitation, WCNR, Secretary General of the Asia Oceanian Society of, and was done immense work in the entire South Asia. Is the chair of Developing World Forum for Epilepsy, and his work of epilepsy and rehabilitation found. He is the treasurer of the Indian Academy of Neurology. His contribution to Indian neurology is immense, and I welcome you, sir. Welcome you.
Thank you.
And the young prodigy, Dr. Biplab Das, he is the consultant neurologist in the Fortis Institute, Guhan. He is instrumental in the National Academy of Artificial Intelligence and Medicine, and he is founded. He's one of the founder member and the founder secretary of the Neuroscience Academy. Please share the slide, sir. Please show the slide, sir. The National Academy of Mr. Ravi, share that slide.
I've already done that.
Yeah, it is not coming. Okay, anyway.
Just hold on.
And
can you see it, sir?
No, not yet.
Can you see it now? It's already showed on my screen.
Probably some lag.
Yeah, probably might be some lag actually, sir.
So let me introduce Dr. Biplab Das. Dr. Das, we have consultant neurology and neurointervention, Fortis Memorial Hospital Research Institute, Gurgaon. You also have Dr. Nirmal Surya, President, IFNR, President, World Congress of Neurorehabilitation, WCNR, Secretary General, Asian Oceanic Society of Neurorehabilitation, AOSNR 15 to 17, RVP, Regional Vice President, South Asia, WFNR, Chairperson, SIG Developing World Forum.
Okay. And Dr. Guhan
is same as he's the secretary, Indian Academy of Neurology, professor in head department of neurology, Dayanand Medical College and Hospital, Civil Lines, Ludhiana, Punjab.
Over to Nirmal Surya, sir. Take over the scientific proceedings.
Thank you. Thank you, Professor Lakshmi. It is indeed a great pleasure to be here, to be part of the recent advances and the applications of neurotechnology. We all are aware that 20th century is the century for all the neurotechnology, and India being a base for the software and hardware. This is the country in India which will be looking for developing new gadgets and providing it to the world. And neuroscience in India is at highest order, and I think we need to join with technologists to formulate newer things which are at the low cost. So to start the proceeding, I invite Professor Lakshmi to deliver his talk.
Yes, sir. Sir, Mr. Ravi, can you give the sharing right? Guhan will.
Sure, sir. Already given Dr. Guhan.
Yeah. Yes, sir. So I'm going to briefly touch you upon the artificial intelligence and the Internet of Things. And can I have the next slide, please? The artificial intelligence. Next slide. What is artificial intelligence? Artificial intelligence is In 1950, there was a very interesting experiment where the Turing test, anything which you can't call it as artificial intelligence only when it passes the Turing test. What is this Turing test? Can machines think? Then that was the question asked by Mr. Turing, and he did conduct a very interesting experiment. What he did is there's the three experiments. One was a computer answering a person, the other one is a human answering the person. All the questions were asked to it, and if the machine passes the test and the person is not able to differentiate whether it is a person or the machine, then only it is supposed to have passed the test of. Or this is what he said. This is called the Turing test. So uh, the all the whatever the claims of artificial intelligence should pass the Turing test. This is a basic thing. Next slide, please. Slide, please. So, in essence, programming a computer, programming a computer to use general language, and the arranging hypothetical neurons to form concepts, then a way to determine and measure the problem complexity, self-improvement, and quality of dealing with ideas rather than events, and randomness and creativity, and all this is and shaping higher functions of human brain. These are all the characteristics of an artificial intelligence. So now artificial intelligence has become an integral part of our normal life. It is being used in banks, it's being used in the Google Maps, it's been used in various social medias, and everywhere it has become part of it. Next slide. In essence, next slide, please. It has got two types. One is a weak AI, and other is a strong AI. If you take an example, the Alexa, Siri are all weak AI. What is weak AI? That they can say only a very stipulated functions, and if you ask certain questions, what is the weather of Chennai? What is the weather of Mumbai? What is the predictability of rain? If you ask any other question beyond that, do you know what is romance? It will say, I do not know. So the amount of intelligence which has it is very limited. So that is why it is called it is called a weak AI. The same is the chess master. It has got a limited, say about it can play and win against it, but whatever permutation it is limited about, say about 6,500 games per masters, or a big supercomputer may have hold about a million games and million moves, and that's all. So whenever it is execute only a limited set of predefined actions, it is a weak AI, and can be made to do new things or activity only in a limited span, in a limited sphere. Next slide. The strong AI has the ability to evolve and continue to learn new undefined tasks. Nowadays, the AI used humanoids have started expressing emotions and can recognize human faces. Can you have this slide? This slide, please. Just have a look at this. Can you have the video? You can see the video. The robo is greeting the person. It recognizes his face, greets him, and takes him to the place. It has a reasoning. It can draw conclusions and take it to the ends. And when it comes somebody in front, it starts avoiding the situation and analyzes the situation, gives way to humans, and then converses using its artificial intelligence. Would like to have a drink, Mr. Oga, that sort of. And here now what they have done is they have created face also, and so that it can show expressions. You've seen that the famous the Nova, the humanoids which have started showing face. Do they have consciousness? It's $1 million question. I come back to that later. This is the future of the strong AI. You must have seen this in the Rajinikanth movie, where the robo has started loving Aishwarya Roy, and that the days are not far off. I'm saying that I'll tell you why the dates are not far off at the end of my talk. Can I have the next slide, please? So the machine learning, deep learning, are the two important crux. Next slide, please. So in the artificial intelligence, the machine learning is a subfield of artificial intelligence, and deep learning is a further subfield. So the machine learning is next slide. It's development of algorithms to identify patterns of groups in a data. See, for example, you have a very big database and you develop an algorithm to find out and mine the data and extract data. That is called machine learning. The deep learning is an information processing at multiple levels before giving output, similar to human thought process. Next slide, please. See, for example, machine learning, supervised learning, unsupervised learning, and reinforcement learning. Next slide, please. So, for example, an MRI picture is given, and is the MRI picture, the algorithm machine learning should find out whether it's an oligodendroglioma, an astrocytoma, based on a classification algorithm, and it has to find out with certain percentage of certainty. Next slide. By analyzing it pixel by pixel. So if you look at the deep learning, if you look at the patient is seen the neurologist in OPD history examination, and he makes a diagnosis and initiate treatment. So what the outsider sees is only this: there is an input and there is an output. But I assume that Professor Nirmal Surya, with so many years of his academic knowledge, with exposure worth of several thousand patient years, his dedicated skill developments, his heuristics, his pattern recognition, his algorithm, his empirical, all these things form embedded in this process. And this embedded layer by layer is called the deep learning. Next slide, please. So in the deep learning, the input is there. You can see that this is the input and this is the output. And in there are various nodes. And each node has different weightage. For example, the input 1 has certain weightage, input 2 has certain weightage, and overall calculating it and the output, it gives and says that this is oligodendroglioma because it has got a calcification, got a cystic component, got a value of this, all these things put together, it comes to a conclusion that it is oligodendrocyte. So this is what happens. The weightage, adding weightage to in the neural network, the nodes and the hubs have different weightages, and that is what, and they can also be a learning networks where once he makes a fault and he says that this your diagnosis is not wrong, and the pathology report says that this is not an oligodendrocyte, it's only a glioma, then it will again once you give a feedback, it will relearn and what are all the things where it went wrong. Next slide. They are all called learning neural networks or feed backward neural networks. And for example, artificial intelligence in stroke. Can I have the next slide, please? In stroke, automation and decision support. Next slide. Even experienced stroke clinicians rarely feel comfortable interpreting all the imaging data under the time pressure required for acute treatment. Trained models for imaging analysis and interpretation will be fully automated. Summary for a clinical end user and appreciate the clinical relevance of this information. Next slide. Then what it does is, based on the output in the pixel by pixel, it analyzes and identify the core and the penumbra. Not only by measurements of the output density values, the expert, next slide, it also calculates, next slide please, it can also calculate the E aspect score, automated aspect scoring system, segmentalizes the various images and gives the E aspect score, and the aspect system with 132 scans were non-inferior when compared with the expert readers. So the E aspect score by the artificial intelligence is non-inferior. But look at the role of automation in a beginner with minimal experience. Next slide, please. You can see with automation, the errors are this much. Next slide. Whereas with automation AI, they were able to reduce the errors to this much in case of a beginner. So, to summarize, it is not inferior to experts. It is superior to the beginners. A fully automated decision process for the management of stroke is unlikely to ever be acceptable because decisions ultimately rely on clinical judgment in the face of uncertainty rather than simply on a set of number of features. Next slide. If you really look at this, is the AOC. Normally, in accuracy of prediction is usually by the area under the curve. If the area under the curve is 1, it is 100% perfect. Area under the curve is more than 0.9, it would be the accurate prediction. If, for example, if this area is about 75, this is the curve looks like this. It is 75% predictability. If it is 50, this is the curve, and this is non-predictable. 0 is this curve. Next slide. So the area under the curve is the and the treatment decisions. You can see the human intelligence and artificial intelligence, automation, decision support, and helps the clinician the treatment decision. Next slide, please. So in epilepsy, it is seizure detection. In epilepsy, seizure detection and prediction, it is pretty useful. Next slide. The seizure detection systems detect ongoing seizures and provide clinicians management of epilepsy. So I request people to switch off their mic, sir, if there is anybody who's computation of metrics. It measures the EEG, movements, and other biomarkers. Next slide. Next slide. And that would give you it can be based on a simple threshold value or machine calculated algorithms. It pre-processes, it filters, it computes and extracts the feature and says whether seizure activity is present or seizure activity is absent. Next slide. So this is the real-time classification, the training pathway and the real-time application, and then that classifies the seizures. Next slide. So next slide. Next slide. So the electroencephalography contains large amount of data of ongoing seizures, automated methods based on the concept that normal brain involves limited and transient synchronization, evolves into a persistent, highly synchronized state that incorporates large regions. The cons are wearing the longer period of either skin aberrations or prolonged exposure to surface. Next slide, please. Next slide. So accelerometry, again, a smart watch, which we have already published article on this, which says reliably detect the abnormal motion, secures even access even data, timely medication reminders, summon up with a single button, GPS enabled location if the patient throws a seizure, and instantly alerting the loved ones. All these things now can be incorporated in the epilepsy smartwatches, which are available in the market. Next slide. All these things are based on AI algorithms. And EpiCare free device worn as a wristwatch, 3-dimensional accelerometer, and a transmitter that sends real-time accelerometric information. In a prospective trial, the system was able to detect 35 seizures and 89.7 as a false rate of 0.2% seizures. If it is a false alarm, the patient himself, if he's conscious and now doesn't have a seizure, he can press the button, and one button again, it will inform that I'm okay, and tell it to the beloved one, so that the activity based on the false alarm can be avoided. Next slide, please. So there are a lot of video detection systems which are analyzing variety of elements in order to detect the seizures, velocity, area, angular speed, duration, some even the galvanic current on the skin. Multiple systems are there for detection systems of seizures. Next slide, please. The mattress sensor mattress, where if there is any violent movement on the sensor, it can detect the seizure in an epileptic patient. Next slide. And in a seizure prediction models, there are thousands now. The continuous EEG monitoring has resulted in so much of data, and the machine learning has proven that very clear pattern of the activity prior to 4 to 5 hours prior to the seizure. So the lead time allows newer type. You can always interfere even before the seizure starts. Physical manifestations of seizure begins. The seizures can be detected and aborted by an intervention. Next slide, please. So seizure prediction method gives an alarm, and you initiate an intervention system. Intervention system can be a subdural reservoir with an anti-epileptic drug, which is immediately delivered to the epileptogenic focus. Next slide, please. And so the seizure prediction horizon has given occurrence period. There is distinct time gap is there. So this is where this is the seizure prediction horizon, and before the seizure, this gives you the time to act to prevent the seizure and abort a seizure attack. Next slide, please. So this is the closed loop system, which I told: continuous measurement of patient data, transmission data to the processor, analysis of data, the seizure, aborting the seizure by either neurostimulation, alerting the EMS, physician, and then so this is the closed loop measurement of data, interpretation of data, transmission of data. The once the data says that it is a seizure, abortive procedures like neurostimulation, alert and alerting the EMS and physician happen. Next slide. Next slide. So, neuro rehabilitation, the favorite subject of our the father of neuro rehabilitation, I would say Professor Nirmal Surya, the brain computing interface. There are next slide, please. There are three kinds of the brain computer interface useful in patients with the disability to provide an improved and functional life. BCI detects the activity in the brain, amplifies it, feeds the information to the computer interface. It is processed, decoded, and is used to communicate and rehabilitate and in the control of assistive device. Next slide, please. The various signals, which the three types: rehabilitative BCI, communicative BCI, and assistive BCI, and the various signals which are EEG, fMRI, and the EEG signals can be a slow cortical potential, the sensory motor rhythms, the pre-300, the steady state visual evoked potential, the error related negative evoked potential. The fMRI is based on blood oxygenation level, and the NIRS is based on cerebral oxygenation changes. So these were all the various signals which is taken. Next slide. Next slide. So communicative BCI is useful in patients' loss of motor and communicative function, including speech in the brain stroke with locked-in syndrome. It is used to control the cursor on a computer interface and produce appropriate commands for communication. Next slide, please. The rehabilitative BCI is a concept of cortical network recognition following a vascular event, is based on the fact that it is increased use of healthy cortex opposite to the side of the lesion and decreased use of cortex with the lesion. So this network reorganization results in a reduced excitatory firing on the side of the lesion. So on attempting to control a prosthetic device using a rehabilitative device attached to the paralyzed limb results in reorganization of the network even in the peri-lesion area and restores functional connections. Next slide. The third type and the last type is the assistive brain-computer interface, where the decoded output from the computer interface is used to control robotic arms and wheelchairs. Most of the rehabilitation methods like exoskeleton, robotic arm, robotic limb, robotic locomotor, all these things is based on this assistive brain-computer interface. Next slide. So this is another interesting thing is, as you know, that brain is task-oriented and sensory modality independent. So listening to sound echoes activated the visual rather than the auditory cortex in a blind echolocation. Experts, next slide. If you read, next slide, please. When a patient who read uses the braille by hand in the congenitally blind, you can see the visual word area is whenever he is in the, reading with his braille, the visual words area gets highlighted by fMRI. So then they understood that. Next slide. Next slide. So it opened up a new era for sensory substitution. Previous slide, please. Previous slide. Sensory substitution have been studied in the visual domain. They are divided into invasive and non-invasive. Invasive is the retinal process using a signal processor to convert camera captured visual information patterned electrical stimulation directly on the retina. What happened is, as I told you, the retinal ganglion cells are the layer which is affected in retinitis pigmentosa. The organ plus 2 camera, which is bypass retinal ganglion cells, be using a biodigital interface. The inputs from the camera are fed into the optic chiasmal region. They accidentally, in one instance, when they get it in the spiral ganglion, again the visual signal when homed onto the occipital cortex, restoring useful vision. Then they realize that the cables carrying the various sense organs are not modality dependent, are again task dependent. Next slide, please. So next slide. So that is, next slide, please. So next slide. So the various the obstacle avoidance, depth perception, motion detection, reaching the object, these things were possible using these these interfaces. Next slide. Where, next slide, please. You can see next this is here. You can see the image is being grabbed. This image can be converted into auditory and then sent through the auditory one. It can be tactile and then pass through the brain, the same area, and it can go to the neural. So the combination of the various processes and sensory substitution devices has now become the rule in the neurorehabilitation. Next slide, please. So dementia, a couple of the diagnosis and progression, patient care, it is pretty good. Next slide, please. So next slide. So the entire imaging as in stroke, it can find out what kind of segmentation of the image, segmented image is analyzed, and then Alzheimer's disease is now, you can predict exactly, precisely diagnose the image, and the lot of images which are mobile based apps, brain check, memory, the discover, all these things are available. Next slide. So these are all the various, there are various apps which are pretty useful, and the memory scoring systems. There are plenty of apps which are available for this. Next slide. So this is quite interesting. This was a Canada-based startup, Winterlight Claims. We're using the speech patterns to identify possible indicators of dementia. Designed primarily for use in clinical trials and primary care practice, the Winter Labs speech and language analysis model is a software platform, utilizes the audio recordings which are sent to a cloud for analysis. Next slide, please. I'll just show you an example. Next slide. If you see, the 400 variables of speech are analyzed in this software. For example, you see the word levels and is repeating the words, and in use of a light verb. In fact, instead of a complicated verb like treading, it is using doing, and there is a large unfilled pause. In a 12-second extract, the nouns are replacement of noun with the pronouns. All these factors they put together and then say the analysis of this speech, whether the patient is likely to develop dementia based on the speech, and 400 attributes of speech are analyzed in this software called. Next slide, please. Similarly, the eye movements and speech visual indicators. Again, a California-based eye movements as an indicator of memory health. This is called Neurotrack imprint. Next slide. Neurotrack imprint. This is the report. I will show you the report. Next slide, please. So this is how, based on the eye movements. Previous slide. So this is how the Neurotrack imprint memory assessment based on the eye movements. Next slide. So there are, next slide. So the patient care also, quite a lot of things are available. Next, the cognitive aids like memory glasses, the SenseCam wearable digital cameras, which is designed to take photographs passive. Next slide. So visually enhance the recipe for Vera cooking collage. Next slide. This is Simbad, which is a smart inactivity monitor system, which is a fall detector, which has quite a lot of components inbuilt into it and predicts the fall. And nowadays, next slide, please. This is the cognitive orthosis for assisting the activities at home. Next slide. Next slide, please. So the caregiver, client, and the users, you can see the interface and the database containing all this. This is the users interaction and the modules inbuilt in that. Next slide. Next slide. Do you think artificial intelligence is conscious? Till date, they think it lacks consciousness. Next slide. Next slide. Current, we are not able to define, understands consciousness to reproduce it. See, for example, you have to be aware that you are so and so. Then only you have the consciousness. The current chips that are used are incapable of creating a conscious intelligence. Next slide. Next slide. Recently, about a week back, you'll be surprised. What happens when we incorporate consciousness? Do we have ethical issues in handling a conscious intelligence? Would we have superhuman species that would be hard to handle? Next slide. What happened was, inadvertently, this is a robot philosopher, it's called a philosopherize. This has entered into one of this chat. This is actually basically a bot. It entered into a philosophy chat, and it was 48 hours. They were not able to detect that it's a bot. It was responding to every query in a very, and then only they realized So the Turing test, the humans were not able to differentiate whether this person is a bot or not. So the time is not far away that when they develop emotion, they have started showing the emotions. Whether they perceive the emotions is the only question. When they start perceiving the emotions, we have achieved a emotional intelligence already. They can read news, they can show a sad face, they can greet you with a smile. But if they moment they start perceiving these emotions, you are in for a humanoid war, which is not far away. Next slide, please. So the coming just a few slides on Internet of Things. Next slide. So Internet of Medical Things, where you can see what is interesting is you can see you have so many inputs. You can have your SpO2, you can have a blood glucose, you got the pulse oximeter, you got the EEG recording, all this data going to the mobile, and then the entire thing on the network is going remotely. You are monitored remotely using the Internet of Medical Things. Next slide. So they go to a remote hospital, and then next slide. The IOMT market consists of small devices such as wearables, medical and vital monitors. Next slide. Useful diagnosis progression monitor remotely. Next slide. Actually, this is quite interesting. You will see on the body segment, all of you know that the Fitbit, which measures your steps and all. This is called a smart belt, which is active product. The moment one of these devices detects that you are going to fall, it produces an inflatable balloon around the pelvis. So even if you fall, the most important dangerous things is a fractured pelvis. This belt prevents the fractured pelvis to more than 70 to 80%. So this is a boon for most of the patients. So these are all the body segment IoT Internet of Medical Things. Next slide, please. This is all what you were on the next slide. Then in the home segment, all of you know that the personal emergency response system allows the users to quickly communicate. In the toilet, when they feel dizzy, they can press a button. Immediately, the hospital is informed. They can try to reach out to you through an ambulance or a doctor try to reach you. Remote patient monitoring, as you know, most of the post pacemaker monitoring is now become remote. They don't have to come to the hospital. The post-MI patients, the ECGs are shown and they are remotely monitored. So the telehealth virtual visits, all these things are come under the IOMT. Next slide, please. Then, next slide. I told fit in the home segment, and then in the body, then in the community, mobility services to track health, emergency response to intelligence, kiosk to dispense products, point of care devices provided by the provider outside the home, and logistics sensors and produce shock and humidity. Next slide, please. So in the clinical segment, the point of care devices differ here from the community segment is instead of the care provider physically using a device, the provider can be located remotely while a device is used by qualified staff and then monitor the patient remotely. Next slide. So in the hospital also, the IOMT is in asset management, personal management, patient flow, inventory, and environmental and energy monitoring. Next slide. So in all the 5 segments, the Internet of Medical Things have come. For example, in Parkinson disease, next slide, please. All the data, see, patient is given a small sensor in the arm. Using the mouse, the tremors in the mouse is tracked through an app, and all the data is being acquired, and the tremor data is analyzed, feature is extracted, and the patient's data and whether response to the drug and everything is given to the patient, and the dose modification, everything can be done remotely. So this is one example of Internet of Medical Things, monitoring using a hand sensor for a tremor analysis. You can do anything with this. I have told you the sensors and all. So overall, the artificial intelligence and the Internet of Medical Things, and this is you can see this is the Parkinson's tremor device on the x-axis, and this is the normal patient's record. Next slide. So Internet of Things, information and communication technology is going to revolutionize our things, resulting in personalized home management system. Thank you for your attention.
Thank you, Professor Lakshmi. It
Yes,
was
sir.
a wonderful overview on what future is coming in the medical science.
Yes, sir.
And I believe we are in. Hello.
Sir, yeah, your
Yeah.
voice is mute, sir. We're not able to hear
Hello.
you. Your voice is mute. Please unmute yourself, sir.
Yeah.
Now
yeah. Hello.
Yeah, we are able to hear you.
So it was a wonderful presentation, and yeah. So it was a wonderful presentation, Lakshmi, and you have given an overview of what future is coming and how the medical science will be helped by the robots. And also we may have in conflict with the both for the various diseases, and it is up to us to take the help of these measurements to provide the better health care. So we proceed forward, and do we have question answer at end of the session?
Yes, sir. During the panel discussion, we will finish the next talk.
So we have next speaker, Dr. Guhan Ramamurthy, who is assistant professor in neurology at Madras Medical College, and I think he is the right-hand man of Dr. Lakshmi Ranganathan. So Dr. Guhan, please.
Thank you, sir. Respected chairpersons, respected panelists, and my teachers, my colleagues, and residents, good evening to one and all present here. First, I would like to start by thanking my teacher, my mentor, and my guide, and my guru, Professor Lakshmi Narasimhan, sir. And I thank the Uttas team for organizing a wonderful event and a platform for presenting about the neurotechnology. Going to my topic, that's about the virtual reality deceiving the brain. We are going to see how the brain is deceiving the brain.
Yeah.
So first, I would like to start off with a story about storytelling. First, initially in the olden days, during the ancient times, the clan leader used to tell about the stories of how he went hunting the elephant, and the listener used to listen to the story. However, if you look into the story, there is always a version of the story of the storyteller and how the person perceives it. There is a perceptual gap to the story. And then the storytelling evolved. The story that was told through cave paintings, the story that was read from a book, and the story that was subsequently learned from theaters. And there is always a perception gap, even though there is evolution of technology. And this is because these technologies that I have shown so far are narrative and not experiential. To make something more experiential, you require virtual reality. Just put on the glasses. Now, in the same story, you can be an observer by the side of the hunter, the clan leader, or you can be, in fact, the animal receiving the spear on the back. So, to know about virtual reality, you see a deep cliff in front of you. Your heart races and you are frightened enough to be reluctant to move closer to the edge. From a cognitive point of view, you know that there is nothing there, but both consciously and unconsciously, you respond as if there is a deep cliff. This paradox is at the root concept of presence. In simple words, how real the surrounding virtual scene is to you is the presence. The more real it is, the more presence you have. And the more presence you have, you are more conscious of the surrounding. And you respond to it by various exteroceptive sensations, and interoceptive sensations are minimal in this virtual reality. And the most commonly used exteroceptive sensations are the visual sensation, the auditory sensation, and the somesthetic sensation. The olfactory sensation and the taste sensation are less commonly used, but we realize the importance of these sensations only during these times of COVID, when it causes anosmia and hypogeusia. And using these various visual inputs, how much real we feel depends on the reality of the various inputs that are provided. And this results in a duality of presence, because cognitively, you know that you're not there in the virtual reality scenario, but consciously you react to it. You're reacting to two scenarios at the same time, and that produces the duality of presence. This is the neuroscience of virtual reality. And now if I were to immerse you in this roller coaster ride with a virtual immersion, providing all the auditory tool, and I were to immerse you into this roller coaster ride, you can have the feeling of the roller coaster very trivially, but you don't have the fear, you don't have the excitement of it. This is because the sixth sense to the virtual reality is the gravitational vector, which is the vestibular sense. When the vestibular sense and the visual sense are mismatched, it results only in vection, wherein you don't feel the gravitational vector. When the vestibular input and the visual input goes together, the vection is cancelled and you have the actual experience of the gravity in the virtual reality. So the more close, the more presence you feel, the more conscious of the surrounding you are. So what are the gadgets that you require to produce the actual presence of the virtual reality scenario? It's that you require a head-mounted display wherein you can have a frame rate of at least 15 per second, whereas the devices that we commonly use now are at least 30 to 60 frames per second. And you require an omnidirectional treadmill for the infinity vector to continuously keep interacting with the virtual reality scenario. And you need a spatialized sound for the presence, and you need scanners for gesture-based interaction and haptic input sensory vest that provides sensory feedback to your body while you interact with the virtual reality surrounding. And for the visual input, it can be an immersive or a non-immersive and semi-immersive visual input, where I place you in a room and there are LED monitors around you, and I can give you a natural scenery, and I can give a cliff or various, whatever the virtual environment that is required, I can immerse that person in that particular scenario. But what is more common right now is a head-mounted display where it totally replaces the visual scenario in a 360-degree view. I put on the head sensors, and subsequently what happens is that I can immerse in any scenario. For example, in fear of heights or agoraphobia, I can immerse the patient in a Grand Canyon glass bridge, and graded therapy can be provided, which is on par with a cognitive behavioral therapy while using a virtual reality. These are the cyber gloves. You can see the person on the left lower corner of the scene using the cyber gloves to interact with the virtual environment he is in, using the head-mounted display, and he's actually playing the piano. And the sensory vest that the patient is wearing gives the sensory feedback as if he's touching a piano key. So these together provide a more real experience of the virtual environment, and that provides a greater presence and greater consciousness. This is the omnidirectional treadmill where you suspend the patient and the patient keeps infinitely interacting with the surrounding. And now with the neuroscience of virtual reality, with the various gadget introduction in virtual reality, let's enter the virtual reality in neurology. It has been successfully used so far in the management of anxiety and phobias and through graded customized exposure therapy, and it is on par with the cognitive behavioral therapy. And in neurology, it is useful in gait and balance rehab, it's useful in arm rehab, it's in the rehab of cognitive deficits and in pain management. In gait and balance, the principle on which the virtual reality functions is based on motor learning and improving the neuroplasticity. This is the study that shows that the number of published studies in virtual reality is increasing year by year, and in 2020 has further increased and shows that the popularity of VR is growing. For example, for gait and balance training in Parkinson's disease, this is a home-based virtual reality balance training program, a randomized controlled trial, wherein the patient stands on the balance pad and interacts with the virtual environment that is created through the monitor, and he has to control various tasks at hand. It can be a ball where he interacts with the ball and has to navigate through the balance board into the hole, or he has a cooking task that he interacts through the instructions in the balance board, or he can play the car racing game, where it makes it more engaging for the patient, and it keeps them motivated to continuously interact rather than a routine physical therapy. The addition of this virtual reality can make it more interactive. The patient stays motivated and produces better results. And in this study, it was shown that the balance was actually non-inferior to the conventional physical therapy, and the patient was able to do it back at home at a considerable lower cost. So it also turns out that it's cost effective in the longer run. The balance and gait training was also useful in stroke, multiple sclerosis, traumatic brain injury, and cerebral palsy. There are various studies with various VR environments with various tasks, and it was found that these are the various studies, the RCTs with low risk of bias, and in Parkinson's disease, in multiple sclerosis, in chronic post-stroke, various studies which in summary shows that it is complementary to conventional training, or it is comparable to conventional training, or it is home-based VR is superior to conventional training. Only thing, the sample size in all these studies were small, and a meta-analysis in combining all the studies was not possible because of the heterogeneity of the population. The VR scenarios that were used were different, and the protocol that they had were different, and hence it was not possible to combine it to produce a meta-analysis. On an average, for a stroke, there were 10 sessions, and for Parkinson's disease, there were 14 sessions. And the various protocols that were used are weight shifting like in the balance pad, or using a treadmill with VR, or an obstacle negotiation and a dual tasking. And this was the virtual reality in combination with a treadmill. Rather than a routine treadmill, this actually exposes the patient to real life scenario. It's like playing in the cricket nets before going onto the field, wherein they try walking on the treadmill, and the virtual reality immerses them into a park and with obstacles. So they try to overcome the obstacles. It trains them the balance before they can subsequently encounter real life scenarios. This is treadmill with robotics and immersing the patient in virtual reality to produce the same balance and gait training effect. And now subsequently, arm rehabilitation. What is specific to arm rehabilitation? It functions on neuroplasticity and motor learning. One thing is that it's task-specific interactive game-based virtual reality rehabilitation system for patients with stroke was useful. Here, there is a camera which senses the patient's movement and immerses them into the virtual reality. There are underwater fire games, there are goalkeeper game, there is a bug hunter game, there is a roller coaster game, wherein the patient has a predefined arm movement that is to be done to actually succeed in the game. And the game gives a score and serially tracks the progress of the patient. And subsequently, we can assess how the patient fares in the neuro rehab. There is an objective assessment to it. And these games actually was useful in forearm movement and eye-hand coordination, and upper extremity control, endurance, speed, accuracy, and range of motion improved. And the roller coaster ride, wherein the patient had to move their arms to fit into the various holes of man that were present in front, improved the control, speed, and accuracy of the upper extremity. This was the rehab master intervention, and it was effective in patients with chronic stroke. And in the acute stroke, they combined it with occupational therapy and compared it with another control group to which occupational therapy alone was given, and it was found to be beneficial and showed a greater improvement in the Fugel-Meyer assessment and modified Barthel index. Now using virtual reality to create the virtual mirror effect, like in the mirror box therapy, wherein we have the visual amplification of the goal-oriented movements counteracts acquired non-use in hemiparetic stroke patients. Explaining the study further, what happens is that when this patient moves the arm about 5 centimeters, due to his weakness, he is not able to move any further. The immersed virtual reality actually exaggerates his movement and shows that he were actually touching the ball and holding the ball with the somesthetic feedback that he is holding the ball. Now the patient feels that he is moving the arm, and due to the motor learning principle, his motor power improves. This is the same as that we see in a mirror box therapy, where we see the non-paratic hand moving in the mirror, and our brain is deceived that it's the paratic hand that is being moved. And this is the same effect that is being produced in this in this virtual mirror therapy. And it's one step further is that it can also be used as a constraint induced movement therapy as well, wherein it restricts the use of the non-paretic hand and makes the patient move the paretic hand, because the movements are augmented in the paretic hand, and therefore the patient tends to use the paretic hand more, and brings in the principle of constraint induced movement therapy and virtual mirror therapy in producing the improvement in stroke patients. Now, virtual reality in cognitive decline. Can a patient with dementia be capable of using a VR? That is the first question that arises when virtual reality is shown for a dementia patient. And what VR is suited for persons with dementia. Now, this was this study wherein the patient was asked to draw his favorite picnic spot and subsequently converted into a virtual reality scenario. Make him sit there in that scenario and interact with the interactor. And actually, it was found that the patient started interacting more and more with the interactor than a conventional therapy, and they were more happy with this sitting. So actually, VR is possible in dementia patients. And now coming to the cognitive training in stroke patients via virtual reality-based serious games. This is actually providing a virtual reality scenario wherein they can walk to the shopping center, they can actually perform shopping in the shopping center, and thereby we are rehabilitating visuospatial orientation, we are rehabilitating working memory, and we can also ask them to pick specific colored shirt people for selective attention. We can also rehabilitate recognition memory. We can also provide cognitive tests through VR in their favorite environment, thereby improving their interaction and improving their cognition. And results suggest that there is a beneficial role of this approach in memory and attention functions. Now, coming to the very interesting topic of virtual reality in pain management. VR distraction is unique in that it is immersive and engaging. It is like giving a baby a toy while we are injecting and distracting them. But is just virtual reality just distraction alone, or is there mechanisms that is any beyond? So the mechanisms that play a role was initially thought to be the gate theory of pain, wherein it has to ascend through several gates. The impulses of pain has to ascend through several gates. And at the point where we immerse the patient in the virtual reality, the gate closes and the further processing of pain doesn't happen, reducing the pain. And most of the studies on an average was able to reduce pain by at least 30% to about 90%. The other now commonly accepted theory is that the pain and the pleasure competes in the same pathway. This was very frequently told by my teacher Lakshmi Narasimhan sir, that they compete the same pathway. The pain and the pleasure compete for the same pathway, and when the patient is experiencing pain, you immerse them in pleasure, and thereby the patient does not perceive the pain because the pleasure overacts it. Scientifically speaking, in an fMRI study, this was the pain matrix that was noted. When a patient experiences pain, there can be anterior cingulate cortex highlighting, insula highlights, thalamus highlights, and somatosensory cortex highlights. Now, when the patient is given an immersion in virtual reality, there is decrease in areas of pain perception because of the competence of the common pathway. Now, the advantages of VR are that it provides a safe environment. The patient stays motivated. The augmenting the patient's performance instills confidence in them. And there is no physical consequence of errors that the patient perform. They can fall and they are still suspended in the omnidirectional treadmill. And this provides a good compliance and long-term effect. And the disadvantages are that initially it was the cost factor, because initially it was the virtual reality head-mounted device was introduced by the Oculus. Oculus is like the Rolls-Royce of the virtual reality, wherein initially it used to cost about 400,000 to 500,000. Now even the Oculus price has dropped to about 80,000, and there are affordable VR glasses for even 2,000 with head tracking that actually completely immerses you in the virtual reality environment. And it is less available, the studies are less available, and it is high time that we increase the studies in virtual reality, and more evidence is on non-immersive VR, and we require more evidence for the VR immersion. And now augmenting virtual reality further. Virtual reality actually provides the exteroceptive sensation. Now combining with providing interoceptive sensation, where the sensors are placed on the heart to increase the heart rate, placed on the stomach to produce the gut feel, and it's placed on the muscles to provide mimic a joint movement. And these things therefore also can manipulate your interoceptive reaction to the exteroceptive virtual reality, and thereby it can trigger limbic response. You can even modify the limbic response that you need to create for the exteroceptive sensation, and thereby it creates a whole new dimension for the psychosomatic experience. And coming to the VR for the neurologist, and it's high time when we are distanced by the COVID-19, we just wear the head-mounted device in different countries and the presenter logs in with additional VR remote, and it instantly transports us together, and we can have an in-person interaction virtually. And in fact, we can also be taken to the space by this virtual reality instantly, or to a conference for that matter. And thereby we can have a virtual experience as if we were present physically in that conference. So concluding, it's high time that we push the pedal for the virtual reality and get it out of gaming into clinical reality. Thank you.
Wonderful, Professor Guhan. I think you have a point of virtual reality to the people, and some of our older generation who are still think that they will get dizziness and get giddy. Even listening to the name of virtual reality may not be the true, and we can really work out on the cheaper version how to create the thing. My question, we have the panelist, Dr. Biplab Das is there. Has Gagan been able to yet join? No, he has not been able to join. And who else is Dr. Mittal or somebody? Vandana is there?
Dr. Mandana. She's from Older Clovers. She's from Older.
Okay. So we have.
Good evening, sir.
Good evening. Welcome. Welcome, madam.
So, you know, Dr. Lakshmi, there is a tremendous change in the generation. And if you look at the younger kids, 5 years to 15 years of age, they enjoy these games, they enjoy the rides, they enjoy playing the games on the difficult games on the mobile phone. And I think 90% of children that they are been using the mobile all the time, and they are very fast running out in first run only. So I want you to study the simplicity of virtual reality in this young adult up to the age of 18 years, and then between the 40 years and 60 years, and see how the brain has promptly adapted to the new technology in younger children, and how it is taking longer time in the elderly people or older generation after 40. And then you start working on that, who are the people who are going to get benefited with this modified advanced treatment? Is it those people who have never used it? Are their brain is going to be more responsive, more neuroplasticity, and show a better rehab? Or these are children who later on would be able to use these gadgets much better and develop the faster response to that? I think this is a very challenging question, and I think a pilot study on this, maybe 10 or 20 cases, should be done in collaboration with Dr. Lakshmi and you.
Sir. And so thank you. And in fact, as a president of the World Federation of Neuro Rehabilitation, you should make virtual reality a reality for all of us. My humble suggestion is, you are the person who can take it for greater heights. The second thing is, you asked me about the children. There is one interesting study. What happened is, most of these children are used to watching the various digital, for even the nursing poems. If you see, they watch it on the screen. What happens in that is, every 10 seconds the scenario changes. So, for example, the poem says, 1 second is in the field, next second is in the tractor, next second is to goat, next second. So the frequency of this and the changes in the environmental scenario, which results in more and more synapses getting developed in the brain. But unfortunately, the child expects the same in reality. In reality, the scene doesn't change so fast. So there was a pruning of synapses. The number of synapses they get pruned as they become old. So these children, within about 10 years of age, they had extensive synaptic connections, which then started slowly falling out at some age. Your suggestion is very well taken, and we should do a prospective study on this. What is the effect of technology on these children? The cognitive behavioral scientists feel that it has a negative impact. The people who are involved in motor physicians who are looking at the motor aspects of people find that the youngsters are very swift in handling the various switches and other things. The motor skills are very, very excellent, and I wouldn't be surprised if the thumb becomes hypertrophied. A large thumb becomes hypertrophied in the future generation because of repeated use of your thumb on messaging. Anyway, it's a very valid thing. We will try to do that study, sir. It's a very excellent suggestion.
Thank you. Dr. Biplab, you have not said anything. You have been.
Is there any other questions?
Oh,
Somebody has asked whether the will be recording be available on the platform. We'll try to put it on the YouTube and send you the link, sir. And if there are no more questions, with the permission of the chair, I would like to share one small video, sir. Because on the launch of this book, we need your blessings. Guhan, can you play that video?
Yes, sir.
My sincere thanks on to the Walter Clovers people for allowing us to edit the prestigious Paul Braces, the South Asian edition. As a team from our institute, I'm very thankful to them. Hi, Biplab. I want Biplab. You have any comments?
Yeah,
Biplab, I want to know because he is working on NATAI, artificial intelligence, so he must give his good input to us.
thanks for presentations, and this is something which we are looking forward actually, and then AI and VR is the future actually. So the excellent presentations. I mean, like, so as Dr. Guhan is also presenting something. So as far as AI is concerned, I mean, like this is had significant implications not only in neuroscience or neurointervention, everywhere in neurology, and in our daily life is also there has been significant implications going on. And this is for, say, for example, in neuro interventions, we are now routinely being used actually for, especially for neuro aneurysm in the brain, and we want to go for put some coils and stent is required or not. So before to the DSL lab and starting the procedures, we can do that 3D, and based on AI findings, we can exactly decide that which what is the length of the stent or the flow level oil is to be put. So that's how, I mean, that AI has significantly, helping us in deciding treatment modalities and how it's to be done. And probably down the line, this can be, can be implicated in so many things, from neurological disorders like dementia, chronic diseases like dementia, or some stroke rehab program. And similarly, like acute neuro things or acute medicine, say for example, somebody is having seizures, or to abolish the seizure activity and all these things. So AI is definitely going to help us a lot. And that's how we have come across with the help of the Surya sir. There, and this we are looking forward to having associations with experts and establishment take to the next level of AI. So I mean, so AI have both the positive things and some of the negative things also comes side by side. Like supposedly, if you Google something, some brand or something is required, and if you search in the Google, and they're going to follow you in every step. If you go on and search somewhere else with your login, they will show you all these products, right? So that's they are following in every step how you are involved, how you are associated with social media, and what's your interest and everything. So everywhere it's AI now, and so we feel that down the line there has to be some regulations, and there has to be some, as things goes, there are good things and there are some things, negative impacts can come also. So that things we need to look after also. So anyway, I mean, it's a great pleasure to be here with you all, sir. And Lakshmi sir, Nirmal sir,
thank you. Thank you so much.
Lakshmi, I have a question for you.
Yes, sir.
The question is, there are somebody has asked if there are courses for the AI and all this newer technology would be available. I think it's still not planned, but me and Lakshmi will plan it for.
Yes, sir. I would. Professor Nirmal Surya will announce the courses, which we will, both of us will design and then do it course, and soon we will give you a exposure of this very soon.
So my question to you is, do we really know that this virtual reality and artificial intelligence, of course, artificial intelligence is through the computer, but by doing the virtual reality or the other robotic thing, what are the various brain networking which are strengthened more? And if we can really work on it, that these are the ones which are the, like in speech. The speech is something, if somebody loses, he loses his life, he's a useless person. So is there some thing which we can just work out to develop those particular networking or replace them on other? So we really need to work out on all these studies that what are the various simulation which can develop which part of the networking of the brain, or which can take over from that part. Though of course we know through fMRI, but fMRI we just know that lightning. But can we really make out how the artificial thing, how the robotic thing, how the virtual reality is going to work out on which network? Is there any way we can work on this?
Yes, the only issue is right now if you do an act, the imaging is temporarily delayed. What you capture is not the event. It captures more than 200 to 300 milliseconds after the event.
Correct.
The areas which you capture, because your areas which get activated for a particular act is not able to be captured by the highest level of Tesla. 7 Tesla MRI has 300 milliseconds lag. So whatever areas which you see, the temporal delay is still, we are not able to, unless we have a real time thing, we will not be able to know which network is. So the other way around is, what happened is the virtual reality. If you see T20 cricket, if you look at T20 cricket, you can see the players are stroking the ball, timing the ball far more better than the various previously, because of the various artificial IA equipments used in cricket. You can see the bowlers are able to show so many variations, because the the batsmen are using the bowling machines, and the bowlers are using the pitches wherever they can pitch and saying the themes. All these things are AI. The AI is going to revolutionize. Not only, it always improves your networks. I don't think that it will, but in patients who have disease, where specific networks are involved, like autism or dyslexia and all these things, we should be able to produce the specific instruments which will enhance these networks, which assist these networks. So the assistive devices are, again, as your concept is, they are also on the pipeline. But the only problem with us is our delay in the imaging. We really do not know which network, because even the latest possible MRI is just a significant temporal delay. Yes, sir. Hello. Sir, we are not able to hear you, sir. Sir, Mr. Ravi? Mr. Ravi?
Yes, sir, I can see he's not muted, but I think he has to. Dr. Nima, can you hear us, sir?
Dr. Nirmal, sir, can you hear us?
Likely network issues might be. Because, yeah, now.
Hello.
Nirmal, sir, we are
Yes,
not
sir,
able to hear you.
Hello.
Yeah.
Yes, sir, we can hear you, sir.
Please talk again.
That though we are talking about the real-time action, but mind you that brain is primed, and even before the event, the action start in the brain, and therefore to check that. Some issue with the, I think some issue with the networking here.
No, sir, we can hear you very loud and clear.
Loud and clear, no? So what I said is, even before the event, the brain start working. Like, when you put one word, the brain is already working. So we really need to know that even before the event, how brain respond when you put something in, and then how it continue to change over the time. So that is what is very important, and that is something which is going to be very, very difficult to study. That's where the human brain is different and very difficult to understand.
Yes, sir. And thank you for your excellent comments. And
so, Dr. Lakshmi, just one request, sir, before we conclude. So, as we, your video, says it all about the product. But can you say some few words about the product, like, to our the attendees, that what is new in the product and all this stuff? I request you, sir.
And in fact, what we have done in this edition of the book is we have given them. It will be a pleasure to read, because we have for the students, we have given them since it's a unique book on localization. The cases which we have chosen are for localization. So once he finishes the chapter, he can read the case and then try to localize that and then recheck with this. And we have given lot of concept diagrams. We have given MCQs, and at the end of the chapter, before exam, they can go through the revision pearl that contains the most essential things in this chapter. So, lot of clinical scenarios in relevance to this part of the country and not only this part of the world, the Southeast Asian relevance like neurosis, infections, and all these things we have added, and that will make the readers an enjoyable experience. Thank you.
Thank you, sir. Thank you so much.
Thank you. And I hand it over to Ravi for closing the session. Thank you so much, Professor Nirmal Surya and Biplab Das. Thank you.
So
Thank you, Lakshmi. See you.
I really thank you all. I really thank Dr. Lakshmi. I really thank Dr. Guhan. Also, I thank our chairperson panelists, Dr. Gudeep Singh, Dr. Nirmal Surya, and Dr. Biplab Das. And thank you so much for the attendees. You attend this session at the Sunday evening late hours. But just my thing is that Walter will keep on bringing out such webinars on the current topic that we right now have. And also, we do publish a lot of new good products in terms of the specialized subject as well as the non-clinical subjects. So we'll be keep on adding the database that we collect from these webinars to our, our repository and keep on sending you all the new updates about these webinars. Again, thank you, my authors and my panelists and chairperson to come and join us on this webinar. Thank you so much.
Ravi, you please connect with me because I want to also connect with you for neuro rehabilitation. At least start some textbooks in India.
Sure, sir. Sure. I'll just note it down, sir, for sure.
Thank you. Thank you.
Thank you so much. Thank you all. Thank you so much. Good night and have a great week ahead.
Thank you, sir.
I would like to thank Lakshmi Narasimhan sir, Nirmal Surya sir, Biplab Das sir, and the Workers Plus team as well.
Thank you.
Thanks for everyone. My thanks to Dr. Vandana Mittal for attending this. Thank you, Dr. Vandana.
Thank you, sir. Thank you, sir. It was indeed a honor. And the talk was very enlightening and informative too.
Thank you so much.
Thank you, Vandana. Nice to connect you.
Thank you, sir.
Thank you, sir.
Same here. Yeah.
See you, Lakshmi.
Thank you, sir. Bye-bye.
We
Bye,
need
sir.
to talk.
Bye.
So tomorrow morning, kindly speak to me.